we might notice that a patient has been on the same therapies for several months and nothing's changed in a review of the patient's chart. We've noticed that the A1C hasn't been changed or sometimes hasn't been tested. We, in those instances, depending on what needs to be done, we'll reach out to the provider and see if they'd be willing to schedule an A1C for a patient, or we may make a therapeutic recommendation if we notice that an A1C was done and there hasn't been improvement, but nothing has changed therapeutically. We'll make a recommendation to kind of move the therapy forward toward that ultimate goal out.
Pharmacists can also, choose a therapy that patients can actually access. So is it covered under their insurance? Can we help get a prior authorization for that? Can we get them on continuous glucose monitoring? We've been able to get some of our patients on that. It's just been a lifesaver for patients. It's really helped us get them in control.
Sometimes it's, the person with diabetes doesn't have an understanding of what their glucose targets are and is very resistant to adding medications because people sometimes have beliefs that, adding more medications is bad or means the health is deteriorating. And so it's really about finding out what is the source of the therapeutic inertia and then addressing that head on.
Our MedSync patients, that's a huge program that we do, being able to get especially our diabetes patients on that program, so we know that they're continuing to be adherent to their medications every month. And then that's just another touch point. That's like a monthly check-in. We would call and say, hey, what medications are you needing this month? We can check in on side effects, see how it's working for them, and then also take the time to do that adherence check and see, okay, they're not adherent or they don't want this medication refilled this month. Maybe we need to dig into that a little bit more.
It may be titrating medications, even something as simple as metformin. We get a lot of patients that, for whatever reason, they get to 1,000 milligrams per day and it doesn't go up from there. So we make sure as a pharmacy team, we titrate them up to that ideal dose of 2,000 milligrams per day.
If we don't overcome therapeutic inertia, what happens is that A1C that was at 8% at the last A1C check 3 months down the road, it's up to 10, or maybe it's up to 9. And time was wasted during that 3 months.
Increased healthcare costs that are going to be coming to this patient down the line for just not taking care of their diabetes up front, or not really having someone to be by their side and kind of educate them and advocate for them when it comes to, okay, what changes do we need to make so that you get that patient buy-in to take care and kind of take responsibility for their diabetes care as well.
This isn't a single disease with a single issue that only focuses on glucose, right? A multi-system disease that has many things that we need to address: cardiovascular risk, renal protection, making sure peripheral vascular disease. They're all still on the radar for us.
What we get concerned about is increased risk of chronic kidney disease, increased risk of heart attack, stroke. Unfortunately, if we don't get those numbers controlled, within an appropriate time span, over time, people will suffer from diabetic neuropathy. They'll have that nerve pain. They won't be able to fall asleep comfortably, blurry vision. And so I always try to assess these things when meeting with people so that I can make the right recommendations. Make sure you see an eye provider, make sure you're checking your feet, things like that. Usually when it comes to providers who see patients in care, these are 3-month, 6-month appointments. And if we're only making one change at those intervals, then we're missing the opportunity to get people controlled quicker, right? And we're potentially lengthening their risk of having some of those complications with those disease states.